Well, good evening, everyone, and very welcome to our Health Professional webinar series. Tonight's episode, a bit of a deep dive into mental health skills for clinicians, and delighted to have our panel tonight, who I'll introduce in a moment. I'd like to first start by acknowledging the traditional owners of all the lands on which we meet across the state and beyond, and pay our respects to the elders past, present, and emerging. So tonight we're going to have a mental skills update. We've got Michael Clements, Mary Emeleus and Johanna Lynch, which I think they're all known to most of you, and very grateful that they've given their time to be with us tonight. So without further ado, if we could go to the next slide, please. Just to remind you that if you have questions, please do put them on the Q&A button at the bottom there. Rebecca Locke, who's co-hosting with me tonight, will be checking the questions and bringing them to the presenters' attention as we go through. Next slide, please. Michael, we will start with you if you'd like to introduce yourself.
Yeah, g'day. Thanks, Peta-Ann. So my name's Michael Clements. I'm one of the rural journalist training advisors with the Queensland Rural Journalist Pathway, and I've got two practices here in Townsville, which unfortunately experienced quite a severe flood last year, and threw most of us GPs into becoming quite practiced at dealing with mental health concerns in times of extreme stress, and we've certainly got many people that are like that right now. So to give away the ending, there's two key things that I want you to remember from all this. One of them is that as GPs, it's up to you to ask the right questions of your patients when they're coming to see you, whether that's for a repeat script or to actually talk about their mental health and their stress. And the next key thing is to learn some key skills and tips and tricks, even if it's just a handful of key phrases or techniques that you're going to hear about soon that you can incorporate into everyday general practice. So this slide here would not be a surprise to any of you. GPs have always provided the bulk of mental health care to our community. Often we see a lot of investment and talk about psychologists and the need to invest more into psychological therapies, and of course that's very important, but only 2.1% of Australians back in 2018 and 19 actually accessed a psychologist. Psychiatrists obviously there for the most significantly impaired or the most complex, and only 1.6% of Australians actually received a service from a psychiatrist, a Medicare related service. Whereas for general practitioners in the same time, 8.7% received a specific Medicare item code that relates to mental health. And so for those GPs here, that's things like your mental health care planning, your reviews, and also just mental health care consults, 2713s. We all know that actually most of our patients have got some degree of mental health to most presentations. In terms of the beach data, that's getting old now, unfortunately, 12.4% of all consultations are mental health related in the tick boxes, but certainly my experience, and certainly during the floods and in the aftermath of the floods, 99% of all consultations in that post-flood environment involved mental health considerations to some degree. And I did a quick Google to look for what do we know about the effect of COVID on mental health, and it wouldn't be a surprise to you that there's a lot of talk about that, a lot of investment. Federal government's released an awful lot of money towards mental health post-COVID, the last batch of it not including anything for GPs, of course. But there was a published paper in the General Psychiatry Journal of BMJ, which looked at some Chinese data. They surveyed 52,000 people in several Chinese provinces, and they found well, 65% of the respondents were females, and almost 35% of the respondents met the criteria for psychological distress, and the burden for that fell heavier on females and the elderly. Next slide, please.
Michael, just before we go to the next slide, I think that's really interesting. Very early on in this webinar series, right when we were looking at emerging information, we did a mental health one, and Brett McDermott was saying on there that if you look at disaster evidence that comes out of disasters, it's often way down the line, isn't it, that months and months afterwards that people really start presenting. But also his point at that time was that he thought that the economic impact of the pandemic is going to be probably even greater than the initial shock of it. What would your thoughts be about that?
Yeah, I think it would agree and certainly say that the causes for the stress are multifactorial, and many of them won't evolve until later. So it might be, for example, isolation in its early stages might be fine, and quarantine might be interesting and fun. Homeschooling for kids may be fun for the first couple of days, but not for longer. And for the right reasons, we're seeing the government open up or relaxing some of the restrictions because we know that there are economic impacts. And those socio-economic impacts of loss of job and employment and job security, we know do lead to things like increased smoking, increased alcohol use, domestic violence, and all of the other co-contributors to poor mental health outcomes. So I think we are going to see that. Interestingly, so we're sort of, 14, 16 months post-floods now. Certainly in the early stages of the floods, we saw a lot of stress, but people not wanting actual psychiatric care, and certainly not wanting referrals for psychological intervention as a general rule. Many people just had to get on with the job. You're often so busy dealing with the immediate disaster and that first 6 months running on adrenaline trying to get everything done that you don't often have time to say, actually, I'm going to go for myself and deal with mental health concerns and see a psychologist. And we're probably in that phase of COVID now where people are still reacting. I mean, every day something new is evolving. So again, I think we're going to see the, or I guess statistical evidence of the mental health impacts take time to show.
That's right. And I think, I'm sure Mary and Johanna will mention this later, but almost it's like the flood hasn't yet arrived. Everyone is prepped and ready for it, but it hasn't come. But everyone's still in that sort of hyper aroused, vigilant, still anxious, very uncertain. So anyway, I'll let you go on.
Thank you. Well, and about that, it's interesting. I think the relaxation of restrictions in Queensland in the last few days has, many people very excited and cheering, and certainly the business owners. And I'm in a shopping centre with lots of small business owners, very pleased. I, as a clinician and as a practice owner, and many other doctors that I talk to, are now more nervous. So our anxiety levels are increasing. I was quite reassured by the fact that we had no community transmission in Townsville.
Exactly right.
Now I've got no reassurance whatsoever.
Exactly.
Every patient that walks in is a risk.
And interestingly, I've seen a lot of patients today, and I don't know, Beck was working yesterday, who are very anxious about that. They had felt very safe, and now suddenly they don't feel quite so safe. Yeah.
Yeah, thank you. So what I did on this slide was try to break down, I guess, those patients, most of the patients that we see, certainly in my practice, I already know. So I'll know them when they make their appointment beforehand. And before they walk in the door, I'll either have an idea of who they are or what their conditions are. And so I'm going to have groups of patients that perhaps didn't have a pre-morbid mental health disorder. And then I'm going to have people that I know are vulnerable, and maybe they were already quite impaired from their depression, anxiety, or other mood disorders, and they're coming to see me. Or I'm going to have people that were well controlled until right now. So in terms of approaching the patients that you see coming in, I think the first thing to do is just ask the question, and it's my question is, how's COVID affecting you? And it's, even before the patient's sitting down or once they've sat down, as I'm reaching for the blood pressure cuff, because I still like to do that, even in COVID times, I still take the blood pressure at the moment. And I just sort of say, well, how's COVID affecting you? I don't really care why they're there at that point. And that often gives me a little bit of an insight into where their head's at. And maybe they're not coming to see me for COVID, but it gives them an opportunity to voice their stress. So we are I've been seeing everything, and I'm sure you've all seen the same thing. So I've got, my network includes a lot of business owners and managers and executives, and there's an awful lot of burnout amongst many of them, just trying to support their staff, trying to keep their company running, worried about, will they have a job? Can they feed their family in the next 2 months or 6 months? A lot of financial employment stress. So people who had very high paying contract work for the mines that all of a sudden got switched off. So people, single income families, I do a lot of men's health. It's very common for men to feel that they want to be the main income earner, and that's part of their identity. And when you take that away from them through a loss of job that's not the loss of their own, their sense of identity and worth just drops through the floor. So I've been seeing a fair bit of that. Some people aren't doing well with isolation. So that might be the grandparents, it might be the parents. I've got a lot of men who have separated from their partners, and the men are isolated from their kids. So they normally have visitation rights. They might be in another state. state, and so we're dealing with the isolation for them. Homeschool is interesting. Many of us thought that it might be a good thing, but the reality of trying to teach 2 or 3 or 4 kids from home and keep them lined up and motivated is interesting. And some of my parents actually had this immense guilt. They thought, oh, well, if I was a better mum, I should be happy that my kids are at home and I can teach them, but they're just driving me crazy, and I just want them to go back to school. Isolation from loved ones, I've mentioned. You know, grandparents in particular feed off their grandkids, and so I had grannies in tears saying, listen, doctor, is it all right if I see my grandkids this weekend? I really need to see them. I realise that it's a risk for me. And I say, of course it is, because obviously in their weighing up of the COVID and their effect on them, that was more important. The other thing is I do a lot with sort of ex-military people. That they have a lot of stress in their life, but they're normally able to burn off that anxiety and stress through exercise. So they get their dopamine hit from a good run. They do lots of physical work, whether that be the gym, whether that be running, and whether that be their hobbies and fishing, and they've lost that. So all of a sudden their normal de-stressing mechanisms have gone. So they're dealing with that. And of course, most of us live from holiday to holiday. I certainly do. And so when you've taken those away, some of those regenerating things that we normally look forward to have gone. And then of course there's those with the pre-morbid disorders. So the pre-morbid people that you're already aware of, and within 2 weeks of COVID lockdowns, 2 of my patients well known to me with known suicidality did actually have an attempt. Thankfully, neither of them succeeded. And it was the COVID was certainly a trigger for them to sort of, you know, it was just another layer on top of everything else that was going on for them. Interestingly, as I said, a lot of my military people are a little bit agoraphobic, maybe introverts at heart. They're loving it. You know, some of my guys think it's wonderful that there's no pressure for them to go out and do anything. They don't have to go out to the shops with their partner. They don't have to, they're not under pressure to socialise or do other things. Sitting at home playing their computer games and Netflix is all of a sudden a healthy thing to do. So many of the patients, when I talk to them, they're actually doing quite fine. And this is the time for OCD. I think many of my OCD patients and their hand washing techniques are actually doing okay. But of course, we know with pre-morbid disorders, there's a propensity for catastrophization and fear. But you know, it's not paranoia if they really are out to get you. So is it really catastrophization when we look at what's going on in Europe and America and Sweden now? And you know, are they really catastrophizing when they say they're worried about the impact on them and their family? Hyper-vigilance, of course. This is an added stress to a vulnerability that's already existing. And of course, access to help is limited. So we are physically, I rely on the tertiary hospital for helping with chronic conditions, whether that be their osteoarthritis or even psych services, allied health services, exercise physiologists. We use exercise physiology in DVA quite a fair bit just for mental health. For many of our soldiers suffering PTSD, part of their treatment plan is the exercise plan. So we get them into the gyms and the exercise physiologists, but they were shut down quite quick. So, and many psychologists actually stop face-to-face visits for various reasons. And many of my patients say, listen, I'm just not happy talking to them over the phone or over video. If it's not face-to-face, I don't want to see them at all. So I've seen them lose some of that normal coping mechanism. So as I said before, yeah, sorry, Peter.
Michael, I was going to say one of the questions that did come through was about domestic violence and an increase in presentations. I know personally I have seen that over the last couple of months, but wondered what your experience was as well.
Yeah, thank you. Being largely men's health, I normally see the perpetrators. And so I do see them with some of my men with just increased agitation, no outlet, no social outlet for them. And it's interesting, we talk about increase in alcohol use, and there are some that have had an increase in alcohol use that like to drink at home and drink to get drunk. But in actual fact, I'd say overall, the alcohol use has gone down in my population because many of my men were social drinkers. And so they're just not socialising anymore. Domestic violence, you know, I worry that I don't see enough of it because I know it's there. I've certainly, my other colleagues in my practice certainly are seeing it. And that's for various reasons. So, you know, we've got people, obviously partners, and domestic violence goes both ways. You know, partners being trapped together. In fact, I've got some lovely couples and I say, hey, you're coping with each other, you know, like, because, you know, I know they're always at each other in my room. So when they're locked together, it's always worth worth just challenging how they're actually going with that. And there's, of course, a healthy fear that those that are the victims in a domestic violence relationship don't have that normal access to go out and socialise or seek friendships or seek connection with external people as a protective mechanism. And so that, I know it's out there. I wish we knew better how to deal with that.
Yeah, thanks, Michael. We might come back to some of that in a minute. I'd like to move to Johanna now, if that's okay. So next slide, please.
Great. Nice to meet you all. I'm a GP from Brisbane who spent the last 15 years working as a therapist with adult survivors of childhood trauma who I met in my community. And I've got a special interest in generalist mental health, the kind of gifts that the generalist gives to the community. When I teach GPs, I talk about how we're actually the most well-trained mental health clinicians in the community. And that's because we see so many people, and we see so many people who are doing well, and we get to pick the early shift to not being well. And that's a skill that actually nobody else has in the community. And a lovely generalist clinician called Ian McQuinney, who wrote about this, said these are skills you cannot learn in the hospital. They have to be learned in the field. And so my main message today is going to be encouraging you to do what you already do. And just to give you a few tips that will hone what you already do. I see that GPs, we offer things that are mostly to do with who we are as people through relationship. Relationship is something we really is central to our work, and we are grounded in the body, which is something that is coming out in the science around mental health, that being connected to the body and understanding how it influences your behavior, your thoughts, your interactions with people when you're stressed is really important for ongoing care. So I'm hoping we'll bring a couple of those skills to you today. I also wanted to kind of say, look, one of the things that we can offer during COVID is being another person that the people can talk to about what's going on. And Michael's question there about how are you coping with COVID is just a beautiful intro to say, look, I'm a witness to what you're putting up with right now. And you can tell me some of what that is during our time together. And that offering of another human being who cares, who sees, is really central to what we can offer our community at this time. I don't think we should think of ourselves as kind of outreach mini psychiatrists. This is not what we're trained for. This is not the work we do. We're not trying to find disorders and nuke them. We're not trying to get rid of symptoms of stress, because stress symptoms are actually really logical and rational at this time. They're actually normal. And so being really careful with our language, I'd really encourage us not to use language that has now become psychiatrized. So for example, the word anxiety, it's now got a very specific meaning. Some would question its scientific background, but it's got a meaning which implies pathology. And there's no need to pathologize our community at this time. Some of the things that happen during trauma is that we grow in connection to one another, we work out who we can trust. We sometimes grow in seeing how strong we are ourselves with coping with things, and we grow in how we see the world. And at the moment, we're facing a bit of grief about our world. We talked a little bit earlier when we were preparing about how, you know, this really is shit at what's going on at the moment. And so that sense that let's grieve that together, let's do that together. And one of the things we talk about that brings safety to people is a sense of solidarity. So we don't have to pretend that it isn't shit. We don't have to make everybody sick who feels it is shit, that actually we're allowed to just do that thing together. And one of those things as GPs is we're in our communities and grounded with people where they're at. That's a gift we can give. So I thought I'd start us with the question, what brings us comfort? This is really a physiological question, but it's also an emotional question, a relational question. And I'm wondering if you could think of something that brings you comfort. I had last night the joy of watching The Beach, which is a fantastic SBS on demand thing, which had just had beautiful images of a man living his life out in a hut on the edge of the sea as the seasons passed, and beautiful images and music. So that's something that happened for me. I'm wondering if you could think just for yourself, what brings you comfort right now? Next slide. This slide's just to remind you that you're a generalist, and that when you see stress, you might see it in the body, and that the host, that's us, responds to stress, whether it's physiological stress or physical stress or emotional stress, in the same ways. So you may see an increased rate of people coming in with angina, allergies, some of the main stress symptoms that we have. And there's that sense of just being aware that you're caring for a whole person whose body's interrelated to itself. There's no need to separate out the mind. And even those stats Michael mentioned at the beginning, we all know that we see more than 12% of our patients with mental illness. It's everyone who we see who's got something going on in their mind and heart at the same time they've got stuff going on in their body and their relationships. And so this is just a reminder that you're allowed to be a generalist and stay true to it. Next slide, please.
Johanna, I might just make a comment there, and I know that you and Mary and Michael are going to talk about this, but one of the questions that came through is, yes, we will bear witness for this. We will talk to our patients. We will, as Michael said, say, so, how are you managing in this tricky time? How do we stop ourselves from getting burned out and stressed?
Yeah, and I think that's part of why I asked you to pay attention right at the beginning of our talk to what brings you comfort. Because as you're all spending time tonight listening out of your families, doing some work again in the evening, unpaid, on behalf of your community. And so I want to honour you for that. And at the same time, really notice yourselves and what you need. When we're finished today, maybe even think about what you're going to look forward to once this is over at 8. And make sure the rest of your evening is something that's relaxing and connecting you to yourself. And we'll give you some skills through the rest of our time today that clarify that. I wanted to pay attention too that when we're being comforted, there's really physiological things going on. Our heart rate variability is changing. We know there's a link between wound healing and the quality of relationships that people have. That this cardiac death rate goes up with hopelessness. And so, the things we do through connecting to others are really central. Next slide, please. This slide's just to remind us that there's normal stress, which is about facing a challenge called eustress. The idea of stress actually came from a medical student in Prague in the 50s or 40s. And then since then, it's been really identified that the difference between stress that becomes damaging, pathological stress on the body, or overload in some language called allostatic load, is the presence of relationship, what we call a buffering relationship. We co-regulate each other and we help one another have adaptive coping and a sense of control in our world. And so this is just a reminder that one of the things that makes a big difference is that relationship which we will be offering in our community. Next slide. The next slides are about skills for you in your room when you're with someone who's stressed. So I think of people being, when they're highly aroused, they can look really agitated or they can look really still. And if they're talking and telling us something, we might hear them talking in a way that's getting more highly emotional and aroused, and the story's starting to take off, and we can feel our waiting room getting pressured as they start getting into full flight. Or we might have the other extreme where we're feeling bored as they tell the story, that it's actually, they've gone down the whole track. It feels like they've told this story a few times before and it's just in a bit of a rut. Both of those things, you can use this beautiful skill that one of the trauma therapists I learned from calls the Art of Empathic Interrupting. And really that's saying that it's therapeutic to interrupt those long speeches and to slow down the conversation, almost use rewind so you get more specific. Can you please, what happened, when you were saying that about your grandma, could you tell me a little bit more about that? So you're getting them out of the rut that they're in, you're bringing them back to language, to listening, if they're starting to get too aroused. And that skill's really helpful for us in the clinical room for other reasons as well, which I'll explain in a moment. If you go on to the next one, please.
Johanna, we've just had one of the questions, and I think it relates to the previous slide you were talking about. Do you believe that stress can reduce your immune levels and increase susceptibility to infections? So just thinking about that physiological response to stressors.
Yes, so if we think about what happens when our bodies are stressed, it changes our cortisol levels, our cytokine levels. This is a really well-established field of research, a transdisciplinary field called psychoneuroimmunoendocrinology. And they've really done beautiful research in this space, confirming what we see in practice. And so, if people want to look that up, there's more information on that. And I actually do cover that in one of the book chapters that are referenced at the end as well. So that might be of some use. So this slide is around a concept called the window of tolerance, which sees emotion like a drug that you don't want to have an overdose of or an underdose of. And it comes from those who work with the traumatized, but it's really, really useful for ordinary practice, that when we're with people, we don't want them to be hyper aroused so they can't think straight, or too kind of intellectualized so they're sort of disconnected from their bodies and from the moment with you. They're not really there. And so we can use skills which help people to get back into the window of tolerance. So if they're getting too intellectual, like telling us, oh, I'm very, very anxious, and sort of starting on a little bit of a spiel about that, we then want to bring them back to their body and say, when you say you're anxious, where do you feel that in your body? So we're bringing them back to here, to telling us something that's really about them, not just an idea or a lingo that's come in from the community. At the other extreme, if they're very highly aroused, then we change the topic. We can use psychoeducation, we can get kind of more practical, more theoretical, talk about it as though we're talking about somebody else, talk about it as though it's if this happened to your friend, what would you do? And so we're taking them away from how aroused they are in their body. And at either end, you can be thinking you're doing really good work, but actually they can't hear you. And so it makes your work more efficient if you keep them in that space in the middle and you learn how to notice when they're going up or down. Okay, next slide. This is a concept which has come again from those who work with trauma, which is the ways we can calm ourselves down. And as I'm talking, can I encourage the clinicians to think about the ways you might be doing this for yourself? So that makes it practical, and you can teach it more easily if you know how to do it for you. But from things that we, as human beings, we can calm down when we make sense of something, when we understand something, when we've seen it artistically, or we've made it into a metaphor, we've understood. When we think about COVID like a flood coming or a cyclone that we're preparing for, those things help us to kind of assess and understand. Humor's in that space as well. Using our imagination to go away to somewhere like our favorite holiday spot and imagine what it's like to be there. Planning things, problem solving, all those kind of things. And conversation, using language is up in that space. Then down from the bottom up, coming into our brainstem, we want to use things that are in our senses. And we now talk about the 5 senses, sight and sound and the rest, but also proprioception, so being aware of where you are in space. So just getting someone to notice where their shoulders are is incredibly calming. And interoception is that kind of awareness of yourself on the inside. Am I hungry? Do I need to go to the toilet? This is questions doctors need to ask themselves. I know about forgetting to go to the toilet. So that kind of like paying attention, how's my gut feeling? Am I unsettled in this room for a reason? So the body can communicate things to us in that way, using rhythm. So thinking about babies, and when we comfort babies, we use tapping, rocking, singing, tones of voice that are calming. All of those things are totally useful for adults. And so learning how to modulate our tone of voice in the room and how we talk to our loved ones as well at this time is useful. Peta-Ann, I can see you're going to ask a question.
Yeah, no, I'm just so interested in that because I'm a lot older than you, I think, Johanna, but certainly I was raised in the Roger Neighbour way of how to conduct consultations, and a very UK thing, but there was this thing at the end, this concept at the end of housekeeping. So at the end of a consultation, after the patient's left, you housekeep with yourself. You check in with how you feel. It's just what you were saying. Do I need a cup of tea? Do I need to go to the loo? Was that a shocking consultation and I've left feeling like this, and why? What do I need to kind of tune in and think about and maybe deal with later, or is it something I actually need to deal with right now? And I think, if there are doctors in training here or medical students, I do believe that that's one of the most useful things that we can teach our junior colleagues. Michael, I don't know whether you have a comment about that.
Sounds like a good technique. I'm normally rushing to the next patient, to be honest, but probably should.
Yeah, I had someone once tell me, when we used to have files you could carry around, to put the one that was really annoying on the floor and jump on it before you went on to the next person. But there's that sense of, what we used to get from closing the file, that's the end of this person, I'm getting myself ready for the next person. And so some kind of symbolic closing or finishing is really important. I think the other thing is thinking ahead, how do I manage myself when I'm in grief over a patient, or I'm in shock, or I'm sad, frightened, angry, even sexually attracted to a patient, how I'm going to manage that proactively, and not leaving it to when you've accidentally got there and you don't know what to do.
Straight into a whole other topic, Johanna. Pull you back.
Yeah, but there's that sense of self-care in this process. Yeah, of preparing yourself. So even if you're new to general practice, I've been encouraging you to think of ways you write or draw or make music, something that's your way of expressing yourself after you've had some pain in your work, because your pain is legitimate as well. Okay, we go into the next one. I'm going to give you some things to practice in a moment. So this is just reminding you of the things that help our brains and hearts to settle, and meaning making, being in community, learning how to manage emotions, and it being normal to learn how to soothe your own emotions, using your senses, having a broad way of seeing. So when you get narrowed view, you can get that catastrophic thinking where you've seen a video from the States and you now think it's going to happen in Australia when there's lots of other evidence to the contrary. And so having that, widening your view again to see the landscape you're actually in, those things are really important skills. Next slide. This is a reminder from the attachment literature. This is used in teaching parenting, in early infant mental health as well, but it's really applicable across relationships, is that one of our tasks in relationship is to provide a secure place for other people where we're somewhere they can be welcomed back to when they need somewhere to come to, but we're also a secure base helping them leave to go out and explore the world. So safe haven is what I meant to say at the beginning, secure base. And this is, for me, also a way to think about coping, that people sometimes need to return to somewhere safe, as to be welcomed and connected and be able to cry or curl up in a ball. And they also need to be able to learn how to explore. So thinking about being comforted and being courageous as things that are signs of well-being. And when we see patients starting to use only avoidant coping mechanisms, that's a place where we can challenge them. So if they don't do any of that exploring, of trying something new, of trying it again, so we see a teenager starting to refuse going to school and not do their normal things, etc. This is a place we can intervene, because the ways that we know that cause pathology is avoidant coping styles. Okay, next slide. This is just a reminder to us. Sorry, I've missed a slide somewhere there around our breathing, but there's a process. If we look at those pictures there about comfort, learning to soothe from the top down, the bottom up, keeping us in the window of tolerance. And there's a lovely phrase from Bruce Perry, which is the idea that we first of all need to regulate ourselves, and that's the clinician as well as the patient, then learn how to relate to the other person, and after that, only then can we reason with them. And that skill's useful in our personal relationships as well. Learn how to regulate yourself, then to relate, and then to reason. And I thought thought as I'd finish up in a moment is to just teach you one of the breathing skills that we can use in a clinical setting. So you can use it when somebody's upset in your room. You can also teach them to use it when they're trying to fall asleep or when they're stressed at home. And that is where you breathe in for a count of 4, hold it for a count of 2, breathe out for a count of 6, because exhalation helps us get into parasympathetic state. Hold it for 2 and then breathe in again for 4. So 4, 2, 6, 2 breathing is a really helpful way to calm the nervous system. And the other technique is...
Can I just ask you, for those people online who maybe haven't done this before, just give us the count, how slow that count is, please.
Okay. Well, as I do that, can I encourage you to join in and do it?
Sure.
It'll help you focus on the rest of the slides.
Yeah, sure.
So it's in, 2, 3, 4, hold for 2, out, 2, 3, 4, 5, 6, hold for 2, in, 2, 3, 4, hold for 2, out, 2, 3, 4, 5, 6, hold for 2. So the end of the 6 starts to get a bit funny feeling, but that's actually what's tripping you into. Yeah. And teaching people so they feel confident to do that in your room. So if you see someone who you know gets highly aroused, but they're now settled with you, you can say, I'm going to teach you a skill, and this is one of the skills you can have. And I'll use it sometimes if I see you getting aroused. So, sort of permission giving to interrupt them and say, look, let's use that skill we just practiced last time. And we can do that. The other one I use is called
I'm going to cut across to Johanna. Sorry, I'm going to hand over to Mary. It's already 22, so we might, if we get,
okay.
Yeah, so Mary, if we could go to the next slide and move to you.
Sure. So thank you, Johanna. And Johanna and I are both associated with the Australian Society for Psychological Medicine, and we deliver level 2 focused psychological strategies skills training for GPs. And we're currently working with JCU and getting our program reaccredited for this triennium as well. So we hope that that will become available. And if you're interested in that, you can put in an expression of interest through the ASPM website. I am also a generalist. I was a GP for a really long time and did a master's degree in psychotherapy and have ended up making the decision to train in psychiatry. So I'm now a stage 3 psychiatry trainee. I feel very grateful that you still allow me to join in these things. And I have to tell you, I remain a generalist and I struggle every day with trying to squeeze my mind into being a specialist. Next slide, please. So I'm really just going to talk about some foundation skills. I'm probably giving you about 12 months of stuff you might learn in a psychology degree in about 10 minutes. Every single slide has a link where you can go and find out more information. I thought that was the best way to go about it. So this first slides on empathy, I'd like to acknowledge were put together by Richard Lakeman, who's a mental health nurse, senior lecturer at Southern Cross University. So this comes from the work of Egan, and you can learn to convey empathy to someone. So you listen to them and then you say, you feel this emotion because this happened. Next slide, please. So here's some examples. So this lady's saying, I could kill him. He didn't take the kids on the weekend. This is the 3rd time out of the last 6 weeks. And her friend is saying, you feel furious because he keeps failing to hold up his part of the bargain. And you can imagine for the lady telling the story, that feels really connecting and she feels like she's been understood. Next slide. And this is another example. So I keep asking when he's going to come home, but the doctors keep evading the question. And the friend is saying, you feel troubled about what they're not telling you. So they're really good examples of the kind of work we can do every day, listening to our patients, but also we know when we're being heard in that way as well. And Johanna spoke about empathic interrupting, which actually is using this skill. So some words you might say to someone who's getting really distressed is you might say, I can see that these things are very important And I can also see that it's quite distressing for you at the moment. And there's a lot going on right now. What I'd like to do is bring us back to the consultation, and then we might make another time to look at this or something like that. So you're acknowledging what's happening for them, and then you're able to interrupt them. So next slide, please. I really like this. So this would be information I would show a patient. I'd have a piece of paper, I pull it out of the printer, I get a pen, and I say, we need to think about the triangle of well-being. So your mind is embodied and relational. And this is really a different way of saying a lot of the things that Johanna said. So you can't have a mind that doesn't have a nervous system to live in, but a mind also exists in relationship to objects and people outside itself. And people have the biggest impact on us, but we do have to have relationships with things and people outside ourselves. So I use this as a model to show someone how we might address their distress or their difficulties or their symptoms from any of those three perspectives. But equally, if we only do one of them, we're not going to get the best outcome. So I actually use this in all sorts of ways. I just think it's, and actually also, if you have a look at it, it pretty parallels biopsychosocial. So when you're making a formulation, it might be helpful to not just say this person has major depressive disorder, but to think about what's happening in their mind, what's happening in their relationships, what's happening in their body. And that becomes a rich description of what's happening for them. And if you want to read more about this, I recommend this book called Mindsight by Dan Siegel. It's a great overview of interpersonal neurobiology. Next slide, please.
I might just bring up one of the questions that's come from the audience in terms of that foundational skill of being able to express empathy for somebody. They've said that it can be said that we're identifying the source of the emotional discomfort so we can rationalize that distortion. And I'd just like you to comment on that, because my perception is that it's more about being able to effectively convey that I see them, or I see what's causing a problem. So, which may or may not be a distortion. So I'd just like your comment on that on that question.
Yeah, I guess you could use it for that, but I think the main purpose for me is that it's effective communication and it helps to calm the nervous system. So when you feel heard and understood, your sympathetic nervous system, well, your vagal brake switches on and you feel calmer and your thinking brain's more connected. So for me, it's really about actually the relationship, and then it allows the relationship to be more effective and it helps the person feel better. You can use it for other purposes. Certainly people are more cognitive once they've had that empathic understanding. But for me, it's really a relationship skill.
Thank you.
Not but, and
yeah.
For me.
Yeah.
And look, I've just mentioned the vagal brake. Peta-Ann, did you want to ask something?
No. It's a different question that I will when you're finished.
Okay. So I just mentioned the vagus and the parasympathetic nervous system. So a lot of the things that Johanna was talking about is also about activating the brakes in our system and decreasing the influence of the accelerator. If you haven't heard of Polyvagal Theory, I strongly recommend that you find out more about it. And there's a really good little TED talk that the link is there, which is from Seth Porges, who is the son of Stephen Porges, who developed the polyvagal theory. There's a very, very good explanation of how the vagus acts like the brakes and the sympathetic nervous system, the stress hormones are like the accelerator. So I just think as doctors, it's great to have a good understanding of this. Johanna's actually just got her PhD. I'm very proud of Johanna as my colleague and friend and in generalist mental health, specific around the concept of a sense of safety and how we help people to experience a sense of safety, and also how we as health professionals can teach people about that and understand it more ourselves. And that's all related to this, to a nervous system.
Mary, sorry,
yes,
I have a technical request. I love the way you talk, but every time you move your hands, you're knocking something. So so you're going to have to sit on them. Is that all right when you're talking to?
Okay. So the worksheet that I have a link to at the bottom there is from the Black Dog Institute. So they have Mental Health Prac, if people are not familiar with that, which has a great overview of how to use online resources for mental health. So some of the questions at the beginning were, how can I have CBT strategies to use at home or with my friends? There are lots of resources, and this is a good one. This worksheet in particular has got 10 different relaxation techniques. You give it to the patient, you get them to try them all and figure out the ones that work for them, because everybody's different. Next slide, please.
Mary, just before you go, there's been a very interesting question that I love these things because I always learn so much. I had no idea that there's an EMDR app.
Oh yeah, there's lots of EMDR.
Yeah, news to me. And Beck, I don't know if you've used them. So the question here is, would you recommend them for anxiety management, especially for complex PTSD, or are there too many risks? So let's see what our panel thinks.
I would have to say it's quite a complicated answer, and I'm not sure that I can do it justice in this talk. So I do have training in EMDR and I do use it. So there are certain aspects of EMDR therapy that are very calming. So there's something called a calm, safe place, where you teach someone to visualize and experience in their body the sensation of being in a calm, safe place. I'm moving my hands again. And you use very slow eye movements to reinforce that. And I think that that's low risk and helpful. And you can actually do it without the eye movements to some extent. I think the faster apps that get people to move their eyes quite quickly, that put the brain in a state where reprocessing occurs, I wouldn't recommend them for people that didn't already do EMDR therapy with a therapist to start with.
Yeah, I'd add to that there's the main focus of treatment with trauma-informed care is stabilisation or getting a sense of safety in your world, and that includes from your finances to your relationships to how you manage your moods and how you view yourself. And so moving straight into the next phase, which is trying to what they call reprocessing or processing what's happened to you before that has been established, is really unwise. And there are some therapists who do MDR who don't even offer it for people with complex trauma or even veterans trauma because of that limitation and the need for quite sophisticated skills to manage that window of tolerance we talked about earlier. So that would be the piece I'd add to that.
You. Michael, you do a lot of work with DVA and vets. So would you have any comment to add to this?
Yeah, I think I have the same hesitation. EMDR, I think, is a very useful tool for psychologists and therapists to use. So the main therapists I do use for my PTSD patients have EMDR as one of their options in treating the patient. But in most of my patients with PTSD, it's rarely a singular entity. It's really the only thing that's going on in their mind. And so I'd be reluctant to recommend an EMDR app unless it was part of a program where they'd already engaged in it with one of their psychologists and decided that it was safe and appropriate for them, and then they're able to go and use it. And having said that, if it was under that kind of support, I wouldn't take that on myself. I don't consider myself engaged enough to be able to decide whether they're suitable, but I'd rely on the psychologist. But in actual fact, most of the patients in the age group that I treat would be quite open to that, but I'd wait for the psychologist to say that it was part of their overall treatment plan.
Thank you. Mary, we might let you get on because we're going to run out.
Yeah, I'm going to just give you a very brief overview of all these things. So this here, if you haven't heard of it, is based on the research of Martin Seligman and his team. Their question was, what gives people well-being? So he noticed that a lot of mental health research has been on what goes wrong. So what is depression? What is anxiety? How do we treat it? But no one had really done research on how do people maintain a sense of well-being even when bad things happen. And I think this is really useful for our own self-care, but it's also I use it as I call it a scaffold for a conversation. So I will ask patients this every single day, probably 2 or 3 people. What are the activities that give you positive emotions? When do you notice yourself feeling positive or even peaceful, calm, content? What activities do you do that get you so caught up in what you're doing that you don't notice time passing? Who are the positive relationships in your life? And that may include your animals. What gives you a sense of meaning, which you might have to describe or explore a bit more. And what gives you a sense of accomplishment? So that might be small things or big things. It might be surviving difficult things. But those 5 domains came up in Seligman's very big study, tens of thousands of people, 20 years, 7 continents. If you want to find more about that, there's a really good link there from the South Australia Mental Health Research Institute, which has a good overview of the research. But I think that's a really useful skill. And you can ask patients that tomorrow, and you will find that the conversations you have then are really rich, and you have an awareness of what resources they have in their life, which you can then use to work out treatment plans and safety plans, and it's incredibly useful information.
Mary, just to underline that, ever since you taught this to me many years ago, I have used it repeatedly, and it is an extraordinarily useful scaffold for people. I wonder, Mary, how do you think the relevance in this difficult time that we're in, which is difficult, it remains the same?
I think it's more relevant. So
more relevant, yeah.
What I've been doing with people is we might actually do a COVID version of the PERMA. So given that you can't access many of the things that normally help you cope, what can you access? So then we will think through carefully what are the things that you can access in those domains, and how can you remain connected with the people you love even when you can't actually see them. So I actually think it's more important than usual, but it's if you get used to it, it really is just such a useful framework and conversation. And there's lots of other research into wellbeing which is just as valid. It's just this has got an acronym that I can remember easily, and just tried and tested. I know it's really helpful.
And I know Rebecca's going to jump in, but we've just had a quick question from someone saying they feel that a lot of their patients may struggle to answer these questions.
And that's useful information. So if someone has no sense of meaning in their life, that's really important to know. And if they have no positive relationships, that's really important to know. If they have sort of a critical super ego that stops them from ever feeling a sense of accomplishment, that's really important to know. So if you go and read the information, the more detailed research, you'll find ways to ask the question. So for example, in positive emotions, almost everyone feels some sense of peace or connection with nature. So you might actually say, do you ever go into nature? Do you go to the bush? Do you go to the beach? Do you like looking at the stars? And you just get used to it. So it might look a bit unfamiliar right now, but the more you practice it, the better you'll get at asking the questions.
It's a kind of brainstorming with the person where you can expand, again, that broadening their perspective so they can see more than they thought they could.
Okay, next slide. This is just another framework that I also called a scaffold for a conversation. This is also from Siegel and his research centre. It sort of is a bit self-evident, but this is the activities that we need to have enough of in our lives to have optimal brain matter. So given that our mind is living in our bodies, we need all of these things going on. Now, I'm not going to go into details. There's a really good link there if you'd like to have a look at it, but this is another one that I really regularly use with people.
There was a question. Oh, sorry, Michael, go ahead.
Oh, sorry, I was just going to jump in. It's most of the stuff I deal with is the low grade stress. So it's the depression, pre-anxiety space. And when people start coming in feeling under the weather, and when I ask them, how's COVID affecting you? And they sort of sigh. If you delve into this healthy mind platter and you say, okay, well, let's just look at what's going on in your life at the moment. How's your sleep? Do you exercise? Do you normally exercise when things are good? Do you exercise? And particularly men's health, that's really important. Focused on when do you spend time with yourself, with your kids? And normally, so even in that really early stage, if you can help them identify that each of these items on that platter are something that they need to make time for. They actually recognise that that's what's missing. And just a small intervention and a small conversation in our blood pressure repeat script consultation, helping them identify some of their own gaps in these activities in the Healthy Mind Platter, is all you need to do for a lot of patients, to be honest, and that's very common.
There was a question earlier in the evening that I think relates very much to this slide, and that's around sort of social media, and the participant was saying that they try and get people to take time away from their devices or social media, but there's that contrast between connecting, where we can only connect through our devices at the moment, but also trying to take time out as well. So I just thought I'd bring that up here because I think it relates.
Yeah, and Rebecca, I often use this to look at balance. So people often can immediately look at it and go, oh yeah, I've got 5 of them, but I don't have any downtime or playtime because I work all the time. And it's really good for self-care, for our own check-in. Next slide. The resource on the side there is a introduction to CBT that was written originally for psychiatry registrars, but it's fantastic. It's a really good intro to CBT. So if you're a GP and you've never had any training in CBT, it's free, takes about 4 hours to do, and it gives you a really solid grounding in basic CBT. And This Way Up actually is one of the online mental health websites also for patients, and all of their courses are free during COVID time. So this is just the basic triangle of CBT, that our thoughts, feelings, and behaviours are linked. I'm going to leave it at that. You can go and look it up. Next slide. And this is another triangle from CBT. So this is also really called the cognitive triangle. So there's an activating event and a consequence. So someone might get an invitation to a party, and as a result, they feel really good. They think about what they're going to wear to the party. They start getting excited. It makes their day. Another person gets an invitation to exactly the same party. They have a panic attack. What is the difference? So the activating event was the same. The consequence is really different. And the B is used because it's A, B, C. So B is for beliefs. So what's going on in our mind that leads to the consequence? And so that's a really good worksheet there. Remembering what Johanna was talking about, people are not going to be able to do this when they're in a state of physiological arousal. So we need to do a lot of the other things first before someone can necessarily do cognitive work. That Centre for Clinical Interventions in Western Australia is fantastic. This is one of their worksheets, but it'll take you to the website, and there is worksheets for everything you can think of that you might be seeing in GP mental health. And they're all CBT based. They're really, really solid, and you can just look them up and print them out, and there's your CBT intervention. Next slide. Oh, I did it.
Yeah, we'll go back to the previous one if we could, Tara. So I was about to say, unbelievably, we've got 2 minutes to go. We're going to come and ask each of you just to give a sort of final word, but Beck and I had a couple of things to say. Beck, did you want to talk about the supervisor aspect? And we might get Michael to comment on that as well.
You're on mute, Rebecca.
So really just wanted to ask to extend the learning that we've had tonight, and there's really just been little tidbits of great information all the way through. If I was a supervisor and had my registrar tomorrow and said, okay, go and watch this and we'll talk a bit more, what activities would you suggest supervisors could take through to a teaching session over the next couple of weeks with this?
Not to put you on the spot, Michael, but I'm judging you here.
Yeah, so I'm a big fan of the focused psychological skills training. That gives you a little bit of a canter through lots of the other skills. So I do encourage all my registrars to consider adding that to their repertoire because it really does dance you through a lot of these concepts. And the beauty of that is that it gives you an introduction to things like this, Mary's put up, and you can delve into it and pick up little tidbits of skills as you go through. To be honest, some of the challenge that I've got with my trainees is to say, listen, mental health isn't something that you diagnose and refer onwards. It's something that we do as part of our core business. You know, it's don't think about mental health as something that you then you've labelled and move on. It's actually a core part of what we do. Everybody, particularly in Townsville, seems to have mental health diagnoses floating around, and it's just about having the conversation. So what I have been doing with my trainees is just focusing on opening liners for when you want to breach the mental health divide.
Great. And that also takes us back to what Johanna said right at the start about not having that separation between mind and body, that we're generalists and we can see the whole person as a whole.
Yeah, thank you. I'm going to come to Johanna and Mary in a minute just to say a final remark, just to let everybody know you will get a link, a copy of this. All the resources are on, we've got resources in a couple of slides. Johanna, perhaps I'll come to you first and then to Mary to have the last word.
Well, thank you. It's been great just gathering as GPs, and I'm thinking of people scattered all over Queensland, and just want to say, look after yourselves this evening, and come back to that question we asked earlier. What are you looking forward to doing next this evening? Hope it's good.
Thank you. Mary.
Yeah, I also wanted to say thanks for the opportunity to share, with other GPs in this way, and for still allowing me to participate. I feel really at home. And I just wanted to comment on the supervisor question. So I think one of the things that we do as supervisors is provide that empathic connection with our trainees. And that doesn't mean we have to talk about their most personal things, but being able to just help them articulate what it is you feel, just the empathy formula. So you're feeling overwhelmed and uncertain because Mrs. Jones won't stop talking, or whatever it is. So that empathy formula, I think, is that the relationship between the supervisor and the supervisee is doing really important work, just as the relationship with the general practitioner is doing with the patient.
Well, thank you so much. We've skidded in a few seconds over. Just a reminder that we've got dentistry for GPs next year, and a shout out to Nadine Cody, who's in Fiji, who had dialed in to say thank you so much to all of you, and good night.